Okay, so hi, good evening, everyone. So, before we start with this session of revision, let me tell you about iconic subscription where you get Unacademy and Prep Ladder both at a very competitive price. We have a host of features at special classes, and you can enjoy them. One very important thing about the resources, how to utilize these resources. The question bank is actually the key to success. It's having more than 25,000 MCQs, and that too with a very good explanation. And they are all high yield question. And this is one of the only platform which is having a raise a hand feature where you can in the class talk to the teacher. This is a very unique kind of feature I really enjoy. And please, a sincere request for all of you to don't that you should not be missing the free test. These are all for you. So yes, we have every Wednesday, Friday, Saturday, and Sunday we have special test, and the best thing is they're all free. So let us talk about this session now. And the first question is length stride. So let us talk something on this length stride. Yeah. So length stride, all are true except. So all are true except for the length stride. Come on, tell me. Where do you get to see this length stride? All except are true. I'll give you a hint. This is seen in angiomyolipoma. So AML, angiomyolipoma. Yeah. I hope you know what is angiomyolipoma. It's a tumor, benign tumor. So it's a benign tumor and of kidney. What is so special about angiomyolipoma? I'm still waiting for the answer from your side. No, 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 logical thinker. Something else, something else. Meanwhile, let me continue with this. What is angiomyolipoma? As the name suggests, angio means blood vessels, myo means muscle, and lipoma is fat. So it is containing fat also, it is containing muscles also, and it is containing the blood vessels also. Blood vessels also. So no, 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 no. So this is containing aneurysmal vessels. I'll explain. Don't worry. So it is containing aneurysmal blood vessels. Along with that, you have soft tissue. You have soft tissue. That is the muscle. That is the muscle. And then along with that, you have the fat. Do you know what is the problem with oncocytoma? Oncocytoma is also benign tumor, and many of the time we are not able to recognize what is whether it is oncocytoma or no, and then we give a conclusion that the features are suggestive of oncocytoma. However, the possibility of chromophobe RCC cannot be ruled out, and this is a really very, very, very important thing. Very important thing. Very good, very good. Yes, hematuria is the answer. But see, this is the only tumor. This is the only tumor which is containing fat. And since it is containing fat, so it is having a attenuation of around minus 20 Hounsfield. So it is the only tumor of the kidney which is having a negative Hounsfield attenuation, and therefore is confidently diagnosed on what, students? On CT scan. So this is very, 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 very important. It can be confidently diagnosed on a CT scan. Let us talk about this. Angiomyolipoma, and then we'll come back to this. So if you talk about angiomyolipoma, AML, what is the origin of AML? Come on, tell me. What is the origin of AML? This is neuroectodermal, basically. This is neuroectodermal tumor, and this is from PEC. What is PEC? Come on, tell me. PEC, perivascular epithelioid cells, and therefore it is also known as PEComa. So what is PEC? This is perivascular epithelioid cells, and therefore also known as PEComa. When we talk about the presentation, this is very simple and straightforward. Don't mug up. When you mug up, then only you try to actually get confused. The first thing is, why it will not have flank pain. It is a flank mass. So flank, it's a renal mass, so there will be a mass palpable. If it is a mass, there will be stretching of nerves, therefore pain is inevitable. Pain to hona hi hai. Yeah. So flank pain, flank mass, flank pain and flank mass. But it is having a lot of, you can say, dilated tortuous aneurysmal vessels which are prone to get what? Ruptured. Yeah. So if they get ruptured, you will have what? You will have a hypotension, or you can say hypovolemic shock also. So hypovolemic shock, flank mass, flank pain. Yeah. This is what is known as Lenk's triad. So what is the concept of Lenk's triad? This is the concept of Lenk's triad. Flank mass, flank pain, hypovolemic shock. This is what is known as a Lenk's triad. Let us try to understand more important things about this. When you're talking about rupture, spontaneous rupture, so there is spontaneous rupture, and this spontaneous rupture results in a what? Retroperitoneal. Since kidney is a retroperitoneal organ, there will be a retroperitoneal hematoma or no? So this is going to result in retroperitoneal hematoma. Retroperitoneal hematoma. So when we are talking about this retroperitoneal hematoma, what is this? What is this known as? So a spontaneous retroperitoneal hemorrhage, a spontaneous retroperitoneal hemorrhage, this is what is known as a Wunderlich syndrome. Yeah, this is known as a Wunderlich syndrome. Wunderlich syndrome. When we talk about Wunderlich syndrome, yeah, what is the most common cause of this Wunderlich syndrome? But most common cause is angiomyolipoma greater than RCC. Greater than RCC. It can be seen in RCC also. One more important thing, what is the management of Wunderlich syndrome? What is the treatment of Wunderlich syndrome? Come on. The treatment of Wunderlich syndrome is angioembolization. It is angioembolization. So angioembolization is the treatment of choice. It is the treatment of choice. Next, very important thing. What is the management of this AML? Acha. So we have already got the answer to the question, which is not acute flank pain, flank mass, hypovolemic shock and hematuria. They all are present. They all are present in AML. But what is not a part of Lenk's triad? Hematuria is not a part of Lenk's triad. But in AML it is present, but it is not considered as a what? A Lenk's. It's not considered as a part of Lenk's triad. But treatment of choice for angioembolization is the treatment of choice for Wunderlich syndrome. Basically, what is the treatment for AML? Do you know this is the only tumor which can be confidently stamped to be benign? बाकी सारे ट्यूमर कंफ्यूजन में रहते हैं, therefore we prefer to go for resection. Why? Because we know that most common renal tumor is malignancy and it's not having a good prognosis. RCC is not having a good prognosis. So AML less than 3 cent. Sorry, I'm having a, you can say, sore throat. So less than 3 centimeters. Basically less than 4 centimeter is the window. So less than 4 centimeter we go for observation. More than 4 centimeter. The problem is the vessels which are tortuous, they tend to get what? Damaged. Yeah. So more than 4 centimeters, the first line is we try to embolize those vessels where we feel that there's a risk of rupture. So angioembolization. And if it fails, you have to go for partial nephrectomy. So I hope this concept is clear. So we discussed one question on angiomyolipoma and we discussed each and everything about that. So let us go to discuss the next question. Chalo, tell me about this. Preferred treatment for ureteric transection of transection at distal third of the ureter. So if you see, this is something like this. The lower end of ureter has been damaged now. This is how the damage looks like. Come on. Side to side repair. Come on. मतलब, I feel pity about the spammers also who come to my class and post something like someone has posted vor.ong. मतलब कहाँ इनको क्या लग रहा है, मतलब they don't know the scenario of doctors in our country. बेचारे वो हमको स्पैम करना चाहते हैं, हमारी तो जिंदगी ऐसे ही लग चुकी है. वेरी गुड केविन, वेरी गुड केविन. इट इज इम्प्लांटेशन. मतलब ये बच्चों के साथ स्पैम कर रहे बेचारे, इनको यही नहीं पता. इंडिया में आए तो ये हम ही को कुछ ना कुछ दे के जाएंगे. नहीं नहीं नहीं, आपके साथ ठीक में गलत हो रहा है. इजंट इट? डॉक्टर्स, अब हमसे और क्या लेना है आपको? ट्राई टू अंडरस्टैंड दिस. लेट अस अंडरस्टैंड द कॉन्सेप्ट ऑफ यूरेट्रिक इंजरी. When we talk about ureteric injury, what is actually the most common cause? The most common cause is iatrogenic. But it is during surgery that you damage the ureter. Yeah? Then try to understand one very important thing. What is the investigation of choice? Answer is retrograde pylography. Retrograde pylography. So retrograde pylography, this is what is. Yeah, hysterectomy is the most commonly done. And you know, this is more common when you're doing a Warthin's. When you go towards the cervix, the cervico-vaginal junction is the place where actually the ureter is very close. And that is why laparoscopic hysterectomies are associated with less injury, because you have a better and magnified view. If you properly separate, like I do a lot of hysterectomies by God grace, not even one single injury has been reported, because we strictly stay in the planes. We do dissect the cervico-vaginal fascia, that vesico-vaginal fascia, and then we clearly lateralize the ureters. The problem is many people don't know how to do a proper surgery, and there they actually damage it. So retrograde pylography is what is the investigation of choice. Now, on one side we will write the site, and one side we will write the treatment of choice. And then I'll explain them to you. बच्चे, नहीं, ऐसा नहीं है. Gynae people do a lot of mistakes, but the problem is they're not having a proper exposure in hysterectomies, etc. The problem is most of them are engaged in obstetrics. So gynecology part is bit, you can say, misleaded. They don't get a lot of time. Once they start doing gynecology, they will master that also. So proximal one third injury, middle one third injury, and lower one third injury. So proximal one third injury, middle one third injury, and lower one third injury. So let us talk about the treatment of choice for them. Proximal one third and middle one third, we prefer to go for end-to-end ureterostomy. So ureterostomy. So end-to-end ureterostomy. The next very important thing is, if we talk about the lower one third, we do ureteric reimplantation. Don't worry, I'll show them to you. What is this? Suppose if this is the scenario, if this is the injury, okay. So what is the management? Bring the two ends together and suture them. Yeah. So ultimately you will land up with the image like this. This is what is known as end-to-end anastomosis. This is preferred for the proximal also and for the middle one third also. For both of them we are doing this. But see, the problem is, if you go to the lower part of the ureter, it's very narrow there. And whenever you do the repairs, you do it over the plastic stents. Why? So that the stricture never happens. But in the lower one third, distal one third, the chance of stricture is really very high. So if it is actually the lower one third injury, then how to manage this? This is again very important. So you don't anastomose. you just seal this end and you do reimplantation. You do reimplantation. How do we do reimplantation? A submuscular tunneling. What is that technique known as? This is known as a Lich-Gregor technique. This is known as a Lich-Gregor technique. What is a Lich-Gregor technique? This is a submuscular tunneling. Submuscular tunneling. This is what is Lich-Gregor technique. Now, bache, there are 2-3 important questions. What are they? If the gap between them is more, suppose you're not able to approximate them. You're not able to approximate. The gap between them is more. How to manage them? So let us write that also. Let us study that also. In case of length discrepancy. So in case of length discrepancy, how to manage this now? This is important. In case of length discrepancy, you can do a bladder hitch. You can do a bladder hitch. But a bladder hitch is also known as what? Swas hitch. What is Swas hitch? You can do a renal hitch. You can do a renal hitch. What is a renal hitch? What is a bladder hitch? Let us see. No, this is not digestant. This is not digestant. Manasa, I'll tell you better. So bladder hitch is elevation. It is elevation of bladder. Elevation of bladder by suture fixation. By suture fixation to Swas. Is that clear? I'll explain it also. And renal hitch is defined as lowering of kidney again by suture fixation toward Swas. What do you mean by this? Try to understand it here. Suppose this is the Swas. This is the Swas muscle. This is the Swas muscle. Okay. Now the gap between them is more. You cannot bring them and do a tension-free anastomosis. So what are you going to do? You're going to take a bite on the bladder and you are going to fix it with the what? You're fix it with the Swas. So when you do this, actually what are you doing by doing this, by taking this bite? What are you doing? Try to understand. You are taking this system up. Can you see? What is this known as? Earlier it was here. Yeah. Now by suture fixating it, you are bringing it up. What is this known as, students? What is this known as? This is known as a bladder hitch. This is known as a bladder hitch. Try to understand one more thing. What is that? What is that? You can bring the kidney down. You can bring the kidney down. Yeah. By fixing it with the Zerota's fascia. कैसे करोगे बच्चे ये देखो. Can you see what is this known as? This is known as a what hitch? Renal hitch. So lowering renal hitch, elevation bladder hitch. Lowering renal hitch, elevation bladder hitch. Is this concept clear to everyone or no? Is this clear to everyone? Let us move forward. The next is we have something more. What is that? We have a Boari's flap. So I hope this is clear. But Shiv, is this clear? Manasa, is this clear? The concept of this is clear. Okay, the Boari's flap. When we talk about Boari's flap, what do you mean by Boari's flap? It is tubularization of bladder wall. Tubularization of the bladder wall to create a new ureter. Yes, to create a new ureter. How you are doing this? Suppose bache, this is the bladder. Yeah. You'll make a cut on the wall of the bladder. So you'll make a cut on the wall of the bladder. Done. And once you have made the cut, what did you make this cut? Why did you make this cut for? You lifted up the bladder wall. So at this place, now you will lift up the bladder wall. So bladder wall is lifted like this or no? Yeah. The bladder wall is lifted like this. This is damaged bladder. Now what you will do? You will close this bladder here. So the defect is going to be, you will close this defect here so that the urine doesn't leak, but still you have a leaf of the bladder which is out. Yeah. Now what you're going to do, you're going to roll these edges into a tube. So when you roll this edge into a tube, you'll suture it. So can you see, you have actually added the length, of the, you can say, ureter, by transforming the bladder wall into a ureter, and then you can do the end-to-end anastomosis. Yeah. So try to understand, students, try to understand. I will show it also to you how this works, I'll just take a page and I will just show it to you. Just a minute. Okay, just give me a minute. I'll take out a page and show it to you. Just see. Imagine this is a bladder. So what I will do, I will make an incision. And lift up the bladder wall. Can you see I've lifted up a bladder wall? Yeah. And now I will roll this wall into a what? Into a tube. Can you see this is a new tube of the ureter? This is what is new ureter, and then you can attach the existing tube to this. So this is what is known as a Boari's flap. What is Boari's flap? It is tubularization of the bladder wall. Is that clear? So I hope the ureteric injury concept is clear to everyone. Let us move to the next question. Okay, let us talk about this. Kuttner's tumor refers to. What is a Kuttner's tumor? So Kuttner's tumor refers to what? Come on. Yeah, I always wish to use this. I also always wish to use this iPad because I am more comfortable in iPad because of this Lasago tool. I just love this. I can cut anything and I can move anywhere. So it looks very nice. I can explain a lot of surgeries because in surgery we have to do a lot of resection and then anastomosis. Yeah. No. The word, I'll give you a hint. The word tumor here is a misnomer. The word tumor here is a misnomer. So actually we say it's a tumor, but it's not a tumor. Okay, it's not a tumor. So let us try to understand what is the concept of Kuttner's tumor. I'll come back. बच्चे, Kuttner's tumor. The word Kuttner's tumor. This is actually a misleading term. This is not a tumor. It is chronic sclerosing. So chronic sclerosing sialadenitis of submandibular gland. So what is a Kuttner's tumor? It's a inflammatory fibrosis of the submandibular gland. Are you getting this or no? So bachi, what is a classical presentation? Yeah, classical presentation. It's a hard fibrous gland. And it may present to you with a complaint of salivary colic. So may be associated with salivary colic. When you talk about salivary colic, what do you mean by this salivary colic? Let me tell you about this. Do you know with the intake of food, what will happen? The swelling arises over the submandibular gland region. Why this swelling arises? Yeah. So painful, tender swelling over the submandibular gland region. Yeah. On intake of the food. But why this happens? This salivary colic can be seen with anything which causes obstruction. So the cause is obstruction to the salivary outflow. So obstruction to salivary outflow is the reason behind this. Are you getting this or no? So obstruction to salivary outflow. Then why it is known as colic? Why it is known as colic? The reason is that if you see this pain pattern, the pain increases from the baseline, shoots to the maximum with the food intake, and then it goes down. So 2 to 3 hours postprandial, it goes down. So since the pain goes up and then comes back to the same baseline. So pain, if you draw a graph of pain versus time, this is what is known as a colic. A pain shoots up and comes back to the baseline. One or two words on this. If you talk about the salivary colic, the most common cause of salivary colic, what is the answer? Answer is the stones greater than tumors. Is that clear? No? And greater than others. What is the management of Kuttner's tumor? So if you talk about the management, so the management of Kuttner's tumor, answer is submandibular gland excision. Submandibular gland excision. This is what is. So let us go to the next question. Chronic parotitis, no. Dysplastic changes, no. Adenocarcinoma, no. It is a sclerosing inflammation of the submandibular gland. So when we are discussing submandibular gland, I'll discuss one more question. All except are true regarding the adenolymphoma of the salivary glands. Come on, students, answer me this question. All except are true regarding the adenolymphoma of the salivary glands. Come on, tell me. All except are true regarding. Yes. Again, the word, I'll give you one hint. Adenolymphoma. The word adenolymphoma, it's a misnomer. The word lymphoma is a misnomer here. What is it also known as? Come on. No. I'm still waiting for the right answer. This is a question on Warthin's tumor. Again, I'll give you a hint. This is a male predominant tumor. Lower pole of superficial lobe, that is tail of parotid. So if you see, this is the location. Tail of parotid is the most common site. Warthin's tumor. Good evening, Danish. Hi, how are you? So this is the most common benign tumor. This is the second most common benign tumor. And one more thing about Warthin's is, this is exclusive to parotids. So this is exclusive to parotid. If you talk about the association, this is associated with what? Smoking, and also it is associated with radiation. So two things we have already got: exclusive to parotid and associated with smoking. Mostly the salivary gland tumors are unilateral. It is only this adenolymphoma, that is Warthin's tumor, which can be bilateral also. So important is that it can be bilateral, but in less than 10 to 20% cases. Not more than 40% are bilateral. So this is absolutely wrong. They have a predominance of mitochondria, and therefore if you give technetium-99, it is rapidly taken up, and hence on a scan you get to see a hot spot. So yes, we get to see a hot spot or a hot bulb sign on technetium-99 scan. Let us talk about management. So when we talk about the management, let us have an overview of, or you can say, let us have an basic approach to the salivary gland tumor. This is again very, 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 very important. So approach to salivary gland tumor. This is very important. Approach to salivary gland tumors. When we talk about approach to salivary gland tumor, and especially we'll talk about the parotid. So we'll talk about the parotid, and if it is a parotid. But say the first thing that we want to know what is inside. So what is the investigation of choice, students? The investigation of choice is FNAC. When you talk about FNAC, FNAC will tell you two things: whether it is a benign or whether it is what, students? Malignancy. So whether it is benign or whether it is associated with malignancy. But say if it is a benign parotid mass, yeah, it is a benign parotid mass, then the next thing that you need to know where it is. Is it superficial? Is it superficial, or is it involving the deep lobe? So superficial lobe, or is it involving the deep lobe, or both lobes, or both lobes. So superficial lobe or deep lobe or both lobe. If it is involving the superficial lobe, students, if it is involving the superficial lobe, then what is the management of this? You have to go for superficial parotidectomy. Superficial parotidectomy. What is superficial parotidectomy? The entire superficial lobe is removed. Yeah, the removal of entire superficial lobe. If you see this, this is something like this. You know that there's a nerve which is going on. Yeah, we have a marginal mandibular vein which is going through this. So marginal mandibular vein also is going through this. So what is superficial parotidectomy? Excising the entire superficial lobe, exposing the nerve naked. Now what's the drawback of this? When you're doing this dissection, you have to dissect the the parotid parenchyma away from the nerve, and the microscopic injuries that occur on the nerve. I'm not saying that you're going to grossly transect the nerve, which is a possibility. That nerve injury is very common. Even if you have carefully done, there will be some level of neuropraxia. So post-operative, you will have those facial nerve paralysis like symptoms for maybe 2-3, maybe 10 days also, maybe 2-3 weeks also. So superficial parotidectomy, point number one. And then in order to avoid this, just a minute. Okay, so let us talk about one more thing, which is known as suprafacial. It is suprafacial parotidectomy. What is suprafacial parotidectomy? Yeah, suprafacial parotidectomy is wide local excision of the lower pole tumor. So try to understand this. Try to understand. Suppose this is the thyroid I'm saying thyroid. This is the parotid parenchyma, and here you have the tumor. So what is suprafacial? What is suprafacial? Instead of removing the entire lobe, you can just go for wide local excision of the lower pole mass, and this is what is known as suprafacial parotidectomy. Nowadays majority of the centers have shifted to this. So suprafacial or superficial, it's a wide local excision. Next is if it's a deep lobe tumor, or if it is involving both the lobes, what is the management? Answer is you will go for total conservative parotidectomy. What do you mean by total conservative parotidectomy? Yeah, let's say it's a nerve sparing. It's a nerve sparing parotidectomy. Now let us talk about malignancy. If we are dealing a case of malignancy, what is the management? If you're dealing with a malignancy, the next important thing is you're not going to spare anything. So you're going to go for a radical parotidectomy. What are the important things that you're going to resect out? You're going to remove the gland, you're going to remove the duct, you're going to remove the fat, you're going to remove the fascia around the gland, you're also going to remove the lymph nodes, and you're also going to remove the involved facial nerve, involved part of facial nerve. And since you're removing the fascia, you will have to remove the muscle. So what are the two important muscles? You'll have to remove the buccinator also, and you will also have to remove the masseter. Why you have to remove the masseter? Because of the common fascia, paroticomasseteric fascia. Okay, so we have a paroticomesenteric fascia, and then the duct is going through the buccinator. So thus the buccinator is also removed. So buccinator plus masseter plus masseter. Are you getting this? So buccinator and masseter. This is what is the concept of radical. The important thing is when you talk about the radical parotidectomy, all the patients of radical parotidectomy, they are sent for what? Radiotherapy. What about the chemotherapy? Chemotherapy is not for all. Important, there is no role of chemotherapy in salivary gland tumors. The only exception to this is, answer is lymphoma. Do you know lymphoma anywhere in the body? Lymphoma anywhere in the body, the management is same, that CHOP or R-CHOP regimen. Is that clear or no? So when you go for facial nerve reconstruction, what are the options for facial nerve reconstruction, students? What are the options? Come on, tell me. How do you do this facial nerve reconstruction? It's a very easy thing. Come on, tell me. The best substitute. So actually we require a nerve graft. And what is the best nerve graft that we have, students? Answer is a sural nerve. So we have sural nerve. What are the other options? The most commonly used is a greater, or you can say greater auricular nerve. What are the other options? We have auriculotemporal nerves. What are the other options? We have greater or we have lesser petrosal nerves. So greater or lesser petrosal nerve. The advantage is that if you want to have a sural, you have to do harvest from the leg. Here they can be harvested from the very same site. So let us go to this MCQ and let us see. So all except true for the adenolymphoma, I have told you, and the management also I have discussed with you. Let us discuss one more small question. Yeah, supraomohyoid neck dissection involves a removal of. Come on, students. This is a very easy question. Come on, tell me. Supraomohyoid. Not right. Very good. So it is 1, 2, and 3. When you talk about the supraomohyoid neck dissection, so this is a form of selective neck dissection. And when you talk about selective neck dissection, we have SOHND, supraomohyoid neck dissection, which involves removal of level 1, 2, and 3. But we have extended SOHND. Generally we do SOHND for what? Oral cancers. And extended SOHND we do it for what? The you can say malignancy of the tongue, because it has a tendency of having a skip metastasis to level 4. So this involves 1, 2, 3, and along with that 4 also. Then we have the lateral neck dissection. It involves removal of level 2, 3, and 4. And then we have something which is known as a posterolateral neck dissection. We have 2, 3, 4. Along with that level 5. Along with that posterior occipital, and along with that retroauricular. We also have one more. What is that known as? That is known as a central neck dissection. When you talk about central neck dissection, we have level 6. So where are we doing the central neck dissection? We are doing it for thyroid malignancies. So I hope you enjoyed this session. Yeah. I am just ending this session. Probably this is the last session before New Year, and we meet in 2022. I hope you enjoyed. If you enjoyed and if you want more enjoyment, join Plus program. Use the code Dr Dixit. Yeah. So use the code Dr Dixit. Download the app. Look into the special classes. Go through the special classes. Buy the Plus subscription. Do recommend Unacademy to your friends. Do share the links with your friends, and do follow me on Unacademy so that you don't miss any notification of my classes. So I hope you enjoyed this session. Any problem in the part that we have discussed? Yeah. So till then, bye bye, bye bye, bye bye. आज 10-15 का लेक्चर नहीं है. Yeah. Today I'm not having a lecture. Probably this is आज के लिए बस यहाँ से खत्म. We'll meet in the next year. 2022. So tomorrow I've not kept because you must be having some plans tomorrow. तो आज इसीलिए जल्दी ले लिया. ठीक है. Till then, bye bye.